Good afternoon, good evening, everyone. My name is Dr. Onaiso, the Regional Director for Asia Pacific Cancer Challenge Foundation. Let me welcome you all to our third discussion on driving quality of cancer care in Asia, regional discussion series. It is great to see so many of our colleagues in cancer care across Asia joining us today. Today, we have a very strong lineup of speakers who will be exploring how CT can lead the development of resource-appropriate guidelines for the management of patients with the invasive cervical cancer in Asia. As we go through the discussion over the next hour and a half, I will invite you to ask your questions to our panelists via Q&A function chat box, and we will be dedicating time at the end to answer your questions. So before we start the session, we would like to start with the poll question. The question is, in your experience, what is the main barrier to develop resource-appropriate guidelines for patients with the invasive cervical cancer in your cities? And interesting result. Thank you. Majority of the participants answered that this is the cost to develop or implement, and the lack of the time of the heavy workload in the developing the resource-appropriate cancer. Thank you so much. For now, I will hand it over to our moderator, the ceremony for today, Dr. Tomohiro Masuda. Dr. Masuda has been involved in the Indonesian cancer registration training programs in Korea, China, Malaysia, Indonesia, Philippines, Myanmar, Laos, across Asia, and also in the GICR project as the director of the IARC Collaborating Center in Japan, and as the chief of the Division of International Collaboration Research in National Cancer Center. Dr. Masuda has been the president of the Indonesian Association of the Cancer Registry since 2016, and has in the capacity of the cancer registry worldwide. And his lifelong goal is to promote the cancer control based on the global evidence. Dr. Masuda, the floor is yours.
Thank you, Dr. Aonai. So I'll be serving as a moderator during this session. Thank you again very much for making yourselves available for this meeting today. Again, so my name is Tomohiro Matsuda. I'm epidemiologist working in the National Cancer Center. National Cancer Center, we have been working with CCAN for several years. And we know that CCAN is very active in East or Southeast Asian region. And so this time I'll be very happy that we can co-host this session. So as I know that this is the first time CCAN co-host this kind of the seminars meeting with the National Cancer Center or the overseas the research institute. I understand that the aim of this seminar is twofold. The first, to invite the specialists from 4 countries, or maybe more than that, to introduce their trials or their experience in the countries on this the multimodal the cancer control programs. And the next, to motivate all of you, the participants, to come up with a plan of actions in your field. So I really hope that this 90 minutes, the session will incite you or will bring you some insight to do something new in your daily activities. As Dr. Aonai so explained, at the end of the 4 presentations, we will have question and answers, so you can write your questions in the chat. So, okay, so the time is limited. I would like to hand it over to the first speaker, Dr. Shylasree. She is a professor and consultant gynaecological oncologist at Tata Memorial Hospital. And as a first speaker, she will introduce the guide for developing research and resource-appropriate cervical cancer management guidelines. So, Dr. Shylasree, please.
Hi, good day to all. My name is Dr. Shylasree. I'm a GYN oncologist at Tata Memorial Hospital. My role was that of an external expert in the development of invasive cervical cancer guidelines for CCAN. I also conducted virtual tumor boards for Yangon and some teaching sessions for Kumasi last year on topics related to invasive cervical cancer. As you all know, there are several national and international guidelines on invasive cervical cancer. However, standard guidelines like NCCN, ESMO, etc. cater to developed countries with a state-of-art infrastructure and resources. Hence, resource stratified guidelines were developed by various organizations like WHO to address issues of LMICs as a whole. National Cancer Grid, which is NCG, is a similar organization in India which is trying to address disparities and referral systems within the country. Last session speaker, I think Dr. Pramesh, our director, must have spoken about NCG. But most of these countries, including India, Myanmar, and African countries, have huge disparities and heterogeneous healthcare systems within the country itself. So there is always an urban and rural divide in healthcare delivery because of varying geography and policies. None of the above guidelines address gaps in cities and its drainage population in a specific way. So as you all know, cities are the hub for referral and treatment of cancer in most countries. So existing major hospitals in these cities need to introspect on the cancer needs for present and future patients. This is where CCAN is helping cities achieve their goals. Another important area which needs looking at is palliative packages, as the patients would like to stay closer to home when we have declared them as palliative care. All these efforts in one strategic city is like a pebble in a lake which creates a ripple and fills the whole lake eventually. So it has a small snowball effect. If we start in one city, it probably will move on to other cities in a country, and somehow you can get the desired effect. These are general considerations before diving into creating guidelines. As I said before, disparities exist not only among countries but also within regions of the same country. For example, for invasive cervical cancer incidence in India, urban cancer registries have an incidence of 8 per 100,000, which is like developed countries. And rural registries have an incidence of 25 per 100,000, which is like LMICs. Also, the burden of disease depends upon the population of women in reproductive age group in whom cervical cancer is very common, especially when there is no screening. Treatment success is good even in locally advanced cervical cancer, but often depends on expertise and availability of radiation machines, as 2/3 have advanced disease needing chemoradiation. All complex equations for calculations of cost and clinical effectiveness should be factored in for disease intervention before formulating guidelines, otherwise it will not work. Now, the best way to do is a SWOT analysis. The best way to do SWOT analysis in this situation is to make a group of key professionals working in cancer care, and in this particular instance, invasive cervical cancer care. That is what CCAN did with a series of meetings in Yangon and Kumasi. All the information can be collected quickly by this method. Several meetings with the city professionals and administrators, and you know, as an external expert, which I was, the exact situation and gaps in their city for healthcare delivery. So it's a very successful methodology to group in the professionals of a city and then sit together and find out what suits that particular city. So keeping all these points in mind, CCAN developed a guide for resource appropriate invasive cervical cancer management guidelines, which has core sections such as aims and objectives, guideline development methods and processes to be used, implementation and monitoring and revision for future. So let's quickly look at these sections just for the flavor of this talk. The full guide is available, which anybody can access after permission from CCAN. So these were the aims and objectives for the guidelines. The stating the purpose of the guideline itself and the target audience, which is basically healthcare providers for invasive cervical cancer, and to assess the clinical demand and feasible interventions depending upon what resources you have, the best option versus what's the next option. Then to bridge the gap for early diagnosis and treatment, to assess again the resources and expertise for present and for future. So guideline development team consisted of all professionals involved in the journey of women diagnosed with invasive cervical cancers, such as doctors, nurses, support staff, administrators, etc., and also and policymakers. Basically, that's so that when you make a guideline, it helps everybody to implement it, because they've already thought of the problem and the solution in the guideline. So there were internal reviews, external reviews, and administrative reviews. In several meetings we sat down before the guidelines were published, and the final revision and agreement was based on consensus between the internal and external reviewers. It was not voting, it was consensus. And also healthcare delivery was categorized into limited approach, which is basically involving peripheral hospitals where diagnostic and intervention facilities might not be up to the mark, and also enhanced approach, which is in affiliated hospitals like tertiary care centers for a particular city where already they have some existing system which is catering to the population. So the guidelines were finalized and printed. We use the APIM implementation strategy, which is basically to assess the situation, plan, implement, and then subsequently monitor, which will basically serve the core purpose of the guidelines. The whole point of making city-specific guidelines is to see whether we can move the city, a particular city, to a different level, bridge the gap between what is there and what needs to be done for the next 10 years, etc. So basically improving healthcare delivery for invasive cervical cancer despite resource constraint, and particularly suiting that particular particular city of a major country or a major city of a country, is what was being what was being tried in this in making of these guidelines. So it was a very beautiful journey, sitting with the Yangon team, all the professionals, consultants. To the extent I felt there was a lot of bonding, especially in the non-COVID era when we physically went to Yangon. And also they also paved way for VTBs, virtual tumor board meetings, with Yangon team, so that they could put in certain cases which they were struggling, because not because of science itself but because of resources, which was the best option for these patients given the resources or the waiting list for radiation, etc. So we did a few VTBs with Yangon team, and we also did a few presentations with Kumasi in for teaching sessions basically. So all in all, I feel that it was a very successful and a very satisfactory journey which I undertook with the CCAN people in developing cervical cancer invasive guidelines. Thank you very much for your kind support, and also for listening to my talk. Thank you.
Thank you very much, Dr. Shylasree. So this is kind of the basis of today's session, and the presentation was very clear. So I would like to invite the second speakers, Professor Kim Pyone. She is a senior medical superintendent, Obstetrical and Gynaecological Society of Myanmar. So she use in Leo this kind of guide for developing resource appropriate invasive cervical cancer management guidelines, and she adapted this guide to the Myanmar's current situation. So she will introduce the present us the Yangon experience of developing cervical cancer guidelines. So Dr. Kim Pyone, please.
Hello everybody. Today I would like to present about our experience regarding the developing cervical cancer guideline for the management of the invasive cervical cancer. Here is the outline of my presentations. And according to the Global Can Fact Sheet in 2018, cervical cancer is one of the most leading common cause among the women in Myanmar in 2018. And there was each standardized incident rate was about 21.5 per 100,000 women year, and each standardized mortality rate about the 13.1 per 100,000 women a year. I would like to, this slide shows the level of the resources in the referral hospital, these are the public hospital in Yangon City. You can see that Yangon Central Women Hospital and North Hoklapa General Hospital, these two hospitals are the main public hospital which provides the gynecological cancer care, and both of them have no radiotherapy services available. Therefore, the patients from this hospital should be referred to the Yangon General Hospital for the management, for the radiotherapy if they need it. I would like to mention about the city process in Yangon. And Yangon joined the ANCCA initiated in the 2017, and it became the key landing city of ANCCA. The comprehensive need assessment study was done in Yangon City, which was conducted from October 2017 to January 2018 with the participation of the health professionals and from the public and private institution and patients and caregivers. The city executive committee of the ANCCA Yangon priced cervical cancer as one of the 4 priority cancer in Yangon. The key finding in this study were that there is a lack of the standardized guideline for the management of oncology patients, and there was no multidisciplinary team approach. Regarding the treatment option for new oncology patient is not discussed by the multidisciplinary team as a standard practice. Therefore, ANCCA supported the Yangon City Executive Committee and Technical Committee to analyze the needs and to formulate the action plan for increasing access to quality care in Yangon from March 2018 to February 2019. Based on this finding, ANCCA prioritized a project to improve the quality of the cervical care by developing the city regulation to establish MDT in centers, providing cancer care and guidelines for the management of breast and invasive cervical cancer, adapted to these local context and the resources. Since September 2019, and this project was implemented by the project team with the help of the project coordinators under the guidance of the City Executive Committee. This slide shows a guideline developing process. I will elaborate detail in the following slide. The very beginning of this project was to set up the project team in September 2019, including the project coordinators who oversight the project and implementation, then provide the technical guidance to the project team member and coordinate with the city stakeholders to engage in the activities of the project. First of all, we developed the Drug Zero guideline in October to December 2019 by holding the several technical working group meetings. There, the project team member reviewed the international guidelines, individual treatment protocol, which are reviewed, and then Drug Zero guideline was updated, clinical management guideline on the cervical cancer. Based on the resource available in Yangon and recommendations from the international guidelines, Yangon cervical cancer management guideline was designed in 2 approaches: enhanced approaches for the medical university affiliated hospital, whereby oncological services are available, whereas there is another limited approach for the peripheral hospital, whereby specialist oncology services are not available. So there is next step is to develop the Draft 1 guideline that was in January 2020. By holding the technical consultation workshop technical consultation workshop, we invited all the representatives from the scientific society, heads of the department of the hospital, such as OB/GYN, pathology, radiology, so on, and clinicians from other relevant hospital and representatives of the private hospital. There, they review the drug zero guideline, findings of the drug zero guideline, and then they verify the methodology and the level of the resource in accordance with local context. Their advice and comments during the city consultation workshops were accommodated, and the project team conducted the follow-up discussion to develop the drug one guideline. That the key message in this step is tailoring the treatment recommendations to the city available resource. Once the drug one guideline was completed by the project team, the second ESCO International Consultation Workshop and multidisciplinary team of multidisciplinary cancer management course, MCMC, was organized in Yangon in February 2020. So here, the team, the multidisciplinary team of the international experts from ESCO, SICAN, and its partner institutions review the drug one guideline to validate the stratification of the resource to align with the international best practice to collect their final technical recommendations, then to finalize the draft one, finalize the guideline. So to get the final draft. Here, I would like to highlight some key participants from Yangon City. So these are the head of these are the city executive committee member and chairman and from head of the department of the hospital of the different specialties of the private public hospital, OB/GYN, pathology, so on, and professional society from the private hospitals. Their participation in this workshop really supported in the consultation and reviewing the guideline from different angles of perspective and context. Of course, most importantly, I would like to appreciate the contribution and support of the external experts in reviewing and consulting the guideline and providing their valuable comments and advice as per context and resource available in Yangon City. So after international consultation workshop, the project team worked together again to accommodate the advice and comments from the international experts. Here, I would like to acknowledge Professor Shylasree from Tata Memorial Center, Mumbai, India, and Dr. Rolando from SICAM, who have made the final technical review and supported the development of the final guideline for this project. After international consultation workshop, once the final outputs are ready, the project coordinator and team submitted this draft to the City Executive Committee for approval and submission to Ministry of the Health and Supports as for the endorsement. And the guideline was endorsed in the December 2020. Here, I would like to point out the importance of the leadership of the City Executive Committee and active participation of representatives from Ministry and City in this project is a key factor for successful endorsement of the guideline. However, unfortunately, because of our current political situation in Myanmar, the process for publishing and dissemination to the relevant departments, hospital, development partner at the city level and to the international partner at the global level are pending. Lastly, I'd like to share our key learning point in the development of this guideline. First of all, we have made our best effort to involve all the relevant stakeholders and experts from different sectors and different specialties in Myanmar in the whole process of the development of this guideline. As I already mentioned, another highlight is that the leadership of the executive committee to mobilize the project team and different stakeholders in the guideline development process to persuade the Ministry of the Health and Support for the endorsements of this guideline. Lastly, but not the least important thing is the endorsement of the Ministry of the Health and Support is essential to pursue political commitment for dissemination, capacity building, and implementation of guidelines in the hospital treating cervical cancer patients, not only in the Yangon city, but also other cities of the Myanmar. Thank you very much.
Thank you very much, Professor Kim Pyong-ki. It's really, I really appreciate that you shared us your rich experience, and I was really impressed by this well-organized procedure to establish your adapted clinical management guideline on invasive cervical cancer. Is this guide available for everyone here, or it is only for the government or only for the Myanmar hospital? Yes, so you established this adapted clinical management, the guideline in Myanmar.
Yeah.
Is it available for all the participants, for example, here, or it is reserved in your country? I thought that if you can share this kind of guideline with the others, it will be very, good, and it will contribute to others' cervical cancer control program.
Well, as I already mentioned at the end of this presentation, because of the political situation, the recommendation of this guideline has been pending, and hopefully we will distribute soon after internal discussion in the city cancer project team.
Okay, thank you very much. This guide from the CCAN, is it available for everyone? Is it on, for example, the website of CCAN?
Yes, on behalf of CCAN, may I answer? Yeah, the guide is available on the CCAN website, and then at the event that CCAN can be sharing with all the attendees.
Yes,
and then
so if you are interested in, you can go to the CCAN's website to refer to the guide, how to develop the guideline in each country. Okay, thank you very much. And we are waiting for your question on the presentation. So feel free to ask a question to the presenters by using the chat function. And next, so I would like to invite Dr. Lanka from Sri Lanka, and she will explain from the broader point of view how they are coping with the problem of cervical cancer in Sri Lanka. So the title is the role of the role of civil society and the patient in developing cancer management guidelines. Dr. Lanka, please.
Thank you so much. Good afternoon, and thank you so much for giving us the opportunity to present. And I think the basic purpose of the cervical cancer management guidelines from the CCAN project perspective is to reduce inequity. So as a civil society, we are indeed very happy to be presenting here. And what we would like to do is take you through the Sri Lankan scenario where the Ministry of Health plays a lead role in this effort. If you look at Sri Lanka, I think breast cancer is the highest cancer burden, but next to that, the second highest cancer burden is cancer of the cervix. So it is an important cancer for us to address within the country. And we have been looking at the WHO initiative, and we have placed a lot of emphasis because this is the only cancer which has an elimination initiative. So we hope that we are able to reach the WHO target. We have been following the WHO guidelines on the management, and we'll talk a little bit more on that. So basically, the cervical cancer elimination initiative that was brought forward by WHO, Sri Lanka is looking at that very closely. So our purpose is basically looking at the 90-70-90 target, getting a threshold of 4 per 100,000 women to get a value for elimination. So we have 3 specific areas that we are looking at for cervical cancer. The first 90 target is basically to get 90% of the girls fully vaccinated with HPV vaccine by the age of 15 years. So that's our first target. The second target is basically 70% of the women who are screened. And this is emphasized, a high performance test. And here we are still in Sri Lanka, we are in a pilot phase, which I'll explain later. High performance test, and the target age group is 35 to 45 years of age. The final target where we are looking at in terms of elimination and our guidelines is that 90% of the women identified with cervical disease receive the treatment. So the 90-70-90 target is something that we have put in the forefront when we are looking at the cancer management guidelines. Sri Lanka has a way to go still. I mean, we've compared with the other Southeast Asia regional countries, the CRO countries of the WHO region. So we are at 12.6. So to get elimination, we have to go 4 cases per 100,000 women, and that's the target for 2030. So it's very clear what we need to do as a country. And so we have the primary prevention, the secondary prevention, and the tertiary prevention, and adequate steps are being taken to address that. The first one, if you look at the 90 target of HPV vaccination, I think we've set the target age at 10 years. So that means we are targeting children in grade 6 of the schools, and the interval between the 2 doses is 6 months. And it's a school-based program. And we're quite happy to say, I think a lot of credit goes to the Ministry of Health, that even despite the COVID situation, they've managed to continue with the vaccination program because we still have the data, it's over 70% are being vaccinated with the first one. We've got a 99% success rate for HPV-1 up until 2019, but in 2020 also, despite the lockdown, despite all the difficulties, there's over 70% HPV-1 coverage. I think, again, looking at the different countries, Sri Lanka started the initiative in 2017, where the HPV was introduced. And so our numbers are fairly good. I think we've managed to at least stay over 60%. And so it's a priority area. And the school-based system, this is a very firmly built system that we have in Sri Lanka. And I think addressing inequity, I think using the school system for HPV vaccination, because it's already established system, and we are riding on that system to deliver the HPV vaccination. The launch of the program was in 2017. And the target group, as I said before, grade 6, 10 years, and you vaccinate the children 2 doses between 6 months. So this is a national program. And actually what the civil society role is, there's a lot of advocacy, which is again done by the Ministry of Health. There are 2 units in the Ministry of Health who are covering this area, the Family Health Bureau, and also we have the National Cancer Control Program. So the lead in this is the government, and civil society organizations support that effort together with other organizations to implement this program. So this is our first target of 90% HPV vaccination. Then we look at the screening, the second number, which is 70. So again, if we look at the national program, the National Cervical Screening Program started in 1998. It's a population-based screening, and the target group here is 35 to 45 years. Now, this is where, again, the resource settings come in, and also we look at the WHO recommendation, because currently we are using the pap smear. There are a lot of difficulties, there are a lot of pluses and minuses with that, which we are analyzing. But the good part is that we have done a HPV DNA study. It was a pilot study, and now it was found to be feasible for scale up. So I think a lot of investment from the government with help from various civil society organizations help the government to do the HPV DNA pilot for screening, and the screening coverage with actually the pap smear is about 23%, and the screen positivity is about 3.3%. This is with the pap smear. So again, in terms of the cervical cancer screening, we are following the WHO recommendations where they are promoting the HPV DNA, and the target age group is basically starting at 30 years, every 5 to 10 years. So we are looking at that. The first, actually, in terms of screening, the Rotary played a big part in this. Before the HPV DNA, actually, they were the ones that helped the Ministry of Health to set up the first regional cancer prevention and early detection center. This is a combined center. It has cervical cancer screening, which includes pap smear and also colposcopy facilities. And also it has breast cancer screening as well. They teach the people who come in, the walk-ins, to do self-breast examination. Plus also they have a mammogram and ultrasound facility there as well. So this was a Rotary contribution to the screening process in the ministry. This was a new initiative, actually started in April 2021. This is what was used to do HPV DNA testing, the pilot in one of the districts called Kalutara. And there they found, and 10,000 kits were given. And this pilot led to possibly scaling up of this effort in the coming years. So Sri Lanka will be in line with the WHO recommendations of using HPV DNA testing for screening. The third target we have, the 90% target. I think we're all aware that early detection is the key. So once it's detected early, I think the survival is much more. So in terms of cervical cancer management, we do have national approved standard operating procedures. Guidelines are being done. So definitely the resource setting, the guidelines that have been done by CanCity will be looked into. And that is being done. And also screen and treat, triaging with colposcopy and treatment are all being included in this. Now, as a civil society organization, we look at the whole cancer management pathway. When we look at the cancer management pathway, we looked at the early detection, we looked at the, in terms of screening, we looked at the vaccination program. Our role, I represent an organization called Indira Cancer Trust. We are a registered organization in Sri Lanka. We support the patients in the latter end of the management pathway. So basically treatment, palliative care, and survivorship care. So we are an organization, not only cervical cancer, but we help other cancer patients as well, both adults and children. We do over 20 programs, and that ranges, it's a variety of programs. And we have, our strength is our volunteers. We have about 600 volunteers. We mostly operate in the National Cancer Institute, which is the main institute in Sri Lanka, managing cancer patients. We do have about another 21 hospitals in the regions, but they all filter in. Most of them are being set up and strengthened by the government. So our priorities do fall in line with the WHO priorities. We start from early detection, and we also go up to palliative care. So those are our strategic priorities. And within that, we support, especially in terms of palliative care and survivorship. We help them with livelihood support. We help them with financial aid. We provide them a platform for selling their products. We provide relaxation programs within the hospital. We also provide, we have a very unique program of providing human hair wigs free of charge to patients. We do get, the majority of patients who come to us are breast cancer patients, but we do get cervical cancer patients as well. And we do have a counseling set of volunteers, and we have set up Sri Lanka's first helpline for cancer. And we get about 40 calls, 30 to 40 calls every day. So there are a range of services that we as a civil society organization have been able to set up to support the government's effort in the cancer management effort. And these are also, again, some of the other services we provide. So it ranges from transport, medication, investigations, and it ends up in funeral support as well. Unfortunately, what we see is the government is putting a lot of effort in strengthening the other regional cancer centers as well. But we do get a lot of filtering from the other centers into the National Cancer Institute Maharagama, which is the tertiary center situated in Colombo. when Colombo is the city, it's Maharagama, very close to Colombo in the Colombo district. And Colombo is the city that has applied for the CAN city for the next round as well. And in terms of the civil society organization, I think in Sri Lanka, there are many civil society organizations who are working in cancer. And particularly for cervical cancer, we see the immense role that the Rotary has played in early detection and screening. And for us as an organization, as Indira Cancer Trust, we are committed. Now, cervical cancer is, for the first time, the world is committed to eliminate a cancer. And the role of civil society in that effort, especially in terms of cervical cancer, is well understood. And we are indeed happy to be part of this effort in Sri Lanka. And I end with our traditional greeting of Ayubowan, which means may you have long life. Thank you.
Thank you very much, Dr. Lanka, for your very informative presentation. And I was very impressed by the activities done in Sri Lanka. In my opinion, it is one of the most important things to set up this target number, 90, 70, 90, just for evaluation. We have to really evaluate the cancer control program. And if there is no numbers or if there's no target, it is mere slogan. So this is really realistic, the program, and apparently you already can reach at the target, at least in the HPV vaccination. So I really hope it goes well in the other two areas also. So I would like to introduce the last presenter, Professor Kim Joo-Young. She is a radiation oncologist and senior researcher at the National Cancer Center, Korea. So her presentation is more oriented towards latest technique to treat cervical cancer. So you can consider this as one of the latest technique information in the high-income countries. So Professor Kim, please.
Hello, I'm Dr. Joo-Young Kim. I'm a radiation oncologist working at National Cancer Center, Korea. I'm delighted to meet you all in this online meeting. What I will present today is introducing our multidisciplinary team approach to you so that you can compare your system with us and find something useful. Basically, cancer treatment requires incorporation of multiple different expertise, opinions, and practice. However, every country has a different environment in terms of medical, socio-economical, and cultural conditions. So the nature of implementation of multidisciplinary care varies across nations. But commonly, as medical practice becomes more complex and subspecialized, physicians become busier and busier and can spare only little time for each individual patient. So we often forget this essence component of medicine, multidisciplinary approach. National Cancer Center, Korea, was established with the aim of reducing the incidence and mortality of cancer through research, patient care, education, and training. According to this aim, NCC is composed of 4 different organizations: Hospital, Research Institute, National Cancer Control Institute, and NCC Graduate School for Cancer Science and Policy. Especially the graduate school educates young people in Asian region to study and propagate knowledge in cancer research and cancer policy in their home country. NCC Hospital started with 15 disease-oriented centers. You can see the smaller units of centers named gastric cancer, breast cancer, lung cancer, etc. From this introductory slide, you must have noticed that the NCC Korea is structured as multidisciplinary cancer care institute. From its birth, multidisciplinary care has been the core value of the institute. There are center-based specialists from various fields, and each center has its own pathologist, radiologist, radiation oncologist, surgeons, and medical oncologists. And I myself is seeing only gynecology patients and pediatric cancer patients. Multidisciplinary team conference involves a discussion about difficulty in diagnosis, treatment decision on new patient, operability, whether we need adjuvant therapy, issue of fertility preservation, and treatment decision at relapse, and covers up to molecular tumor board. Recently, there was a big change in multidisciplinary care in Korea. Korean government started to pay for the multidisciplinary clinic because multidisciplinary care requires time and efforts of many people, and no one would ever bother gathering once or twice a week to discuss just one patient. And hospital administrator would not be happy either to allocate such many physicians in such precious time if MDT is not paid well. So it was realized necessary by the government to pay for the multidisciplinary care to encourage physicians and health providers to set aside their time and effort for MDT care. One big difference from the pre-existing multidisciplinary conference is that patients and families are invited at the multidisciplinary clinic and can listen what physicians say. This government support was given from 2014 and has been evolving until 2020, adapting the original reimbursement plan according to the opinions from the real world. It covers not only cancer, but also covers MDT for rare disease or difficult disease. These are the ICD code Korean government covers for MDT. Only MDT at higher level of general hospital is approved because the key element of this system is the presence of specialist doctors from all various fields. It covers maximum 3 times on one patient and one special occasion 2 more times. MDT reimbursement varies depending on the number of specialists gathered in the MDT meeting. Reimbursement rates is from 125,000 Korean won for 3 specialists to 375,000 Korean won for over 9 specialists. Which is about $100 to $300 US. You would think this support is very generous for a government, but actually our other medical fee is extremely low, to our shame. And practicing doctors and health providers are having a great difficulty. But anyway, from our experience, I think there are a lot to take for me as a physician from this type of MDT care. First, it's a forum for continuing education of health professionals. By education, I don't mean only the trainees, but it also involves learning other fields from expert colleagues and steps between non-clinical and clinical parts. And we are also pressed, the physicians are also pressed in the MDT to use more evidence-based treatment. And the MDT gives the opportunity for development of institutional guideline for diagnosis and treatment. So it makes the care consistent. And the other thing is that we can be protected by this multidisciplinary care because everything is written down, everything discussed in the conference is written down, and maybe it can protect us from some lawful condition, I think. And there is another effect by letting people and family know that and witness that doctors care for them. So there is a positive effect of rapport formation between patients and the doctors. And the last thing, but not the least important thing, is that physicians become more democratic in presenting their opinions and become friendly more each other. For patients' prospectus, the benefit is that they can meet directly all different physicians at one time and in one place. Patients come to know that they are cared throughout the disease course and not just at one point. And the patients also can listen to the various ways of treatment, the options of treatment for one condition. The next few slides are the slides of the clinical example that multidisciplinary discussion can result in better treatment outcome. This is a right internal iliac lymph node metastasis in recurrent cervical cancer. And we asked the surgeons to put an augmenta flap around the tumor so that we can give them higher dose of irradiation like this. We use helical tomotherapy for treating recurrent cancer. This is another case, a 16-year-old female who has anal rhabdomyosarcoma. We had to irradiate the pelvis lymph node for this patient as well as anal cancer. And before doing that, we asked the surgeons to transpose her ovaries to avoid irradiation. And she is now regularly menstruating and in very good condition. And sometimes we teach the surgeons to let them know the right place of ovarian transposition. And sometimes we can get some help from surgical oncologist in case of tendon malposition for brachytherapy. These are the all positive effects of multidisciplinary discussion. I said all good things about multidisciplinary care, but I know that there are certainly still limitations in the current MDT at our institute and in Korea. Actually, we feel like we need more protected time to doing that because we concentrate on new patient discussion and diagnosis and so on. We tend to miss the case discussion for morbidity and mortality. And it is actually, frankly, difficult to discuss and explain all detailed things to the patients in front of various specialists because the doctors conflict of interest. So there is a limitation in doing that. And I hope we could have more social care team bringing into the MDT so that we can care the quality of life of the patients. I also hope that the hospice care MDT can occur between the primary doctors and the hospice doctors in the future. So take-home message from our experience is no matter how small or large your working environment, you can always meet and talk. And that is the start of the multidisciplinary team care. Multidisciplinary team care improves patient care and most of all, teaches ourselves a lot. And it improves physicians' communication, which definitely is translated into the better survival and quality of life of the patients. I think that's the end of my talk. Thank you for listening.
Thank you, Dr. Kim. I have been working with National Cancer Center Korea for a long time, and in my impression, the concept of multidisciplinary is really well realized, even in the research field. So, for example, this population-based data are completely kind of fusion into the clinical data, and they realize the big data center in National Cancer Center Korea. So we really have to learn from this kind of the latest and advanced activity in the National Cancer Center Korea. Thank you very much for that 4 presenters. Now we have the voice from the field. The first one is Professor Sohao Tati from Indonesia. So she is the president of Indonesian Radiation Oncology Society, and also head of the Comprehensive Cancer Care Center. She is also a professor and senior radiation oncologist at CIPTO and Faculty of Medicine, University of Indonesia. So, Professor Tati, please.
Thank you very much, Dr. Matsuda, for your nice introducing me in this forum. Good afternoon, everyone. Thank you. First of all, I would like to thank for inviting me for this very special event. I involved the CTCAN since that fortunately twice I was invited to come to Myanmar, to Yangon, a nice thousand of temple city. There I met Dr. Aung. I was there for the first meeting, but unfortunately for the second time I couldn't come due to the COVID pandemic. If I'm not mistaken, it was in February last year. So it was already scary for us to go abroad. All of us agree that cervical cancer is still a big burden, especially in low and lower middle income countries, like many countries still in our region. Also in Indonesia, cervical cancer is still the second highest number of cancer. 9.7% of all cancer patients is around 32,000 new patients a year after breast cancer. And sadly, like also in other low and lower middle income countries, 70% of cases are still found in the late and advanced cases. Therefore, while of course prevention through vaccine and right screening and early detection method is very important, in country like ours, we still have to deal very much on treating the advanced cases that we found every day in our clinics. This is where it becomes very important for us to have a good multidisciplinary guidelines. And of course, the guideline has to be specifically made based on the country situation, on its own resources and special condition. Only then we can have better treatment result, as it is mentioned by previous speakers, and also deliver a cost efficiency. We have already in our country national guidelines for cervical cancer, as well as the national program for pap smear, and we still use the VIA test as well as vaccination, even the coverage is still low. The first foundation, I think, that we have also to build strongly when we want to do the guidelines for cervical cancer. Even this step is not easy. I know many people don't like to do this, that we have to do it. It's to make a good calculation of gap analysis, inspect, write down and analyze what is our condition now and what is the number, our resources that we have to have, and calculate how much do we actually need to perform the basic standard treatment. For radiotherapy equipment, especially cervical cancer, don't forget that we need a brachytherapy in the regimen. No matter how many and how advanced our external beam radiotherapy machine are, if we have not enough brachytherapy machine, that we cannot treat cervical cancer adequately. In Indonesia, we have calculated, just as an example, that we have 20 brachytherapy machine. We calculated from our cervical cancer patient that we would need 71%. It is citated from the IEA publication of them treated with the brachytherapy. So become about 23,000 patients need for brachytherapy yearly. If we give 3 fractions of brachy for each patient, then we would need 69,000 fraction of brachytherapy per year. Then if we divide it by the number of working days in a year and how many working hours you usually do that, we can have how many machines that we really need for our countries. For our calculation, we need 31 machines actually for 3 fractions of brachytherapy per patient. And we have only 20, so the coverage is 65%. Then we can stimulate to use, for example, 2 fractions per patient. So we will increase the coverage nationally, become 100%. That's what I mean, that the guidelines should be based on our own facilities. So it depends on all of you. In resource limited, we need to have as efficient as brachytherapy. If funding is limited to private brachytherapy, To optimize utilization even more, we can adapt the fraction number to give, as I mentioned before, 2 times 8.5 instead of 3 fraction if we have no equipment, for example. So we can have a more coverage of a patient can be treated if we do 2 fraction per patient. But of course, if you want to increase the number of our machines, we should also be in line with the increase of awareness of public oncologists in that field about cervical cancer treatment strategy. Otherwise, it will become underutilized. During my experience as the chairman of National Cancer Control Committee in Indonesia, I also work together with civil society very much. It is important for them to be connected with the medical professional, especially in the part of implementing the guidelines. Doctors can write instructions as much as they want. If the public or patient don't come to the hospital, then it is no use. Please give much careful consideration to all different race, culture, belief, religion, especially as cervical cancer is involving women's most intimate area. They will feel hesitant or scared to be examined or treated, and even the husband maybe also reject to the idea. Civil society here play a big role in increasing the public knowledge, especially on cancer awareness and how to get checked and treated. And so the guidelines can be accepted and implemented well. Also, as a chair of National Cancer Control Committee at that time, I realized one strong point that you would need full support the government from the beginning to the end. This is no need for the guidelines. If after we, for example, as the professional society write a nice guideline, but not telling the doctor or hospital to use to implement it. That's why we need to work closely with the government to socialize, to enforce the implementation of the guideline, and very systematic monitoring and evaluation of the guidelines, implementation of the guidelines. This is a big challenge. Even in my own country, we are still facing this huge challenge, but I hope that if we continue to try, we will get a better with it over time. In the end, anyhow, to move forward in fighting cervical cancer, we have to increase to prevent cervical cancer by vaccination or pap smear, and also to shift our case findings to earlier stages. That's why doing this hand in hand with the government, multidisciplinary medical professional, of course, with the civil society is very crucial. Only by doing this together, we can get closer to eliminating cervical cancer from the world. Thank you very much.
Thank you very much, Professor Tati, for your precious message, encouraging us to, the fight against cervical cancer. Okay, let's move on to this Q&A session, since we have only one voice from the field. Okay, so thank you for the participants for asking the many questions. Finally, let's do in order of the presentation. So the first one, it is for Dr. Shylasree, and it's simple. And if I understand well the questions, how can people access to the guide you presented? So if it is a guide itself, she can already share the URL. You see in chat, so you can just click on this kind of link, and you can have this PDF, the guide.
Yes.
And if the question is just like, for example, how we can apply for this program of CCAN, just like in which was done in Yangon, maybe the answer is different. So if you have some additional comments from Dr. Aung Naing Soe or Dr. Shylasree.
I think
yes, thank you.
the link is Dr. Ronaldo put up the link for the guide for guidelines itself for invasive cancer. That's easy part of the story. The one actual the details of treatment on the intervention and diagnosis of cervical cancer as such, invasive cervical cancer, which we produced in Yangon, I think as Yangon has to agree, and along with CCAN, that can be accessed at some point once the Ministry of Health approves what is said, basically. Ong, you can you answer the second question,
Yes.
please?
Thank you. Thank you so much. The guide link we can be shared again along with the report after the session, and the recording we can disseminate to all the attendees and then the partners. And another question regarding the SICAM process to be implemented in the cities. We have a frequent call of the application for the city of tomorrow and for the SICAM call for proposal. At this point, I can be disseminating the time that the city can be applying for the SICAM process, and then we will have the proper process application due diligence, and then if everything is passed and the city is ready to start for the SICAM process, SICAM will be supporting the city as our ambition is to be improved access to quality cancer care in the regions.
Thank you very much. Yes, this, I think good enough as a question, as the answer. So, okay, let's move on to the presentation by the Dr. Professor Kim Pyone-ki. So the question is, what are the challenges encountered in developing the guideline in Myanmar? Dr. Professor Kim Pyone-ki, could you answer to this question? What are the challenges encountered in developing the guideline?
Well, at the beginning of the project, there was a significant delay in developing the drug zero guideline, as there was no standard operative procedure to guide the project team how to stratify the resources, as well as how to develop the guideline in multidisciplinary team approach. Therefore, we took the considerable time to agree on the approach by the project team in developing the drug zero guideline. Now, I'm very delighted to know that SICAM developed the guideline, how to develop the resource appropriate cervical cancer guideline based on the learning and experience from our Yangon city, and that will support our other cities to develop the appropriate guideline for their own country. Is that the answer?
So, I think so, yes. Okay, I have two more questions to you. So another question is, MDT, this multidisciplinary team, the approach for cervical cancer happening on a regular basis in Yangon, or you just implemented after this project?
As I already mentioned, and the guideline has already approved before currently, but we are not practicing this guideline. But in Central Women Hospital, we have the regular visit of the multidisciplinary care for the early stage of the cervical cancer, involving the pathologists, radiologists in the same hospital for early treatment of the early stage of the cervical cancer. However, for the advanced case and other comorbid patients, multidisciplinary care are involving other departments from Yangon Central Women Hospital, like the radiation oncology, palliative care, and other related surgical care, etc. So we are practicing like this. But a proper multidisciplinary team care is not for every patient as a regular basis with the other department.
Okay, thank you very much. The last one, this is kind of maybe difficult question to answer. So as things stand now, are the patients in Myanmar getting the benefit? So maybe since the political situation is severe, so maybe this guy asked a question, she or he would like to know the current situation.
Right, okay. Well, the guideline has approved by the Ministry of the Health and Support just before this political change of the political situation in our country. Of course, when the things become stable, and where the implementation plan will start soon, I think. I hope so.
Thank you very much. I really hope so myself also. Thank you. Okay, the next question is for Dr. Lanka. Dr. Lanka, how is the access to treatment, especially radiotherapy and oncology and medicines for the cervical cancer patient in Sri Lanka? And how does civil society contribute? This is a question
Okay.
for Lanka.
Right. Thank you so much. I think, as I mentioned earlier, we do have our capital is Colombo, and we have the main hospital treating cancers, which has most of the facilities in terms of radiotherapy also there. In terms of the peripheries, the government initiative is to strengthen the 22 peripheral cancer hospitals. So they are not all hospital has the radiotherapy treatment option, but the government initiative is to strengthen those to basically to capture the radiotherapy as well. Chemotherapy is available. Pediatric cancers are mostly concentrated in Colombo. So the mandate is there from the government side to strengthen the service delivery component throughout the country. In terms, that's the answer to the first question. The second question, in terms of civil society, I think the civil society role in cancer management per se in terms of treatment, although minimal is, what we do is we support any side effects, palliative care, any support care services we can do as organization. And as I mentioned earlier, the early detection and screening part also, the civil society, some of the organizations support that.
Okay, thank you for a very clear answer. Now, one question for Professor Kim. So the question for Professor Kim is, what is the proportion of cervical cancer patients in your center that the decision of the first treatment is taken by MDT?
We do not put all the patients with cervical cancer on MDT because we have been having our institutional guideline and national guideline. So most cases, it is a kind of routine treatment method. But I think about 10% of the patients with cervical cancer is discussed in multidisciplinary care. Nowadays, people begin to treat ovarian cancer with various methods such as radiotherapy and surgery and chemotherapy. So ovarian cancer patients are also very frequently discussed. Yeah.
Okay, thank you. Is it okay? Yes, okay. Next question is for the Professor Tati, the voice from the field. Okay, so the question is, if the worst come to the worst and brachytherapy facility is not at all available, which is the case in Myanmar now. So this is a question from Myanmar. How will you effectively treat cervical cancer patients? This is a question for Professor Tati. Yeah, thank you.
Yeah, thank you very much. So when I got an invitation, I saw that invasive cervical cancer, we know that the accurate or appropriate treatment for cervical cancer is external irradiation combined with the brachytherapy. That's why in my statement before, there is no good treatment for cervical cancer if we have no brachytherapy. Even when I was in Myanmar, in Yangon, I visit also the Yangon hospital, and I saw that they have a good radio external irradiation equipment. And I know that they can do the intensity modulated radiotherapy. Maybe if it is so after the external irradiation, we can give a boost with the MRT technique to the area of rest of the cancer. But anyhow, no external irradiation can replace the place of the brachytherapy. So I mean, Dr. Aung, I think you have to have the brachytherapy in your country. Even the good brachytherapy, we can give a more fractionated brachytherapy, for example, at least 3 times or 4 times, and also 3D. But if we cannot do it because of the financial problem, we can do it, as I mentioned before, 2 times. If we cannot do the 3D brachytherapy, we can do 2D brachytherapy. But anyhow, brachytherapy have to be done. Thank you.
Thank you very much. Okay. So we still have several questions, and one new question comes, and this is maybe for Dr. Shylasree. The question is, what will you do VIA positive cases? I think visual test positive case. So according to the guide, what will you do the VIA positive cases?
Hi. I practice invasive cervical cancers. I'm a GYN oncologist. I don't practice preventive oncology, even though I've been accredited in UK for this thing. We were doing PAPs there and HPVs. Now we've come to VIA because the institution also has a study on VIA. So the VIA is a replacement for pap smear. That's what I would say for most people with all the trials, which is one big trial which has come out of Tata Memorial itself. VIA is an equivalent of pap smear. So if there are some criteria to say VIA positive versus negative versus borderline or whatever, there are pictures which are given to health practitioners and preventive oncologists in the country to say whether it's VIA positive or not. So in a case of VIA positivity, a biopsy is taken. And this is because when you don't, if it is replacing pap smear, a VIA positive disease we can take a biopsy. But generally, if you are in the field, what our preventive oncology department does is see and treat policy with cryo with this, and then they get followed up subsequently with another VIA to see if it is regressed. That is in the field, not in the hospitals, not in the referral centers for preventive oncology. So VIA is somehow, the place of VIA is pap smear. It's an equivalent of pap smear, not the other way around. So if you have, if you can't do a pap smear, a VIA, HPV, and then come to some conclusion, because that's not going to be costly. One-off you can do for some patient where you're not certain what you're doing, but otherwise in field, VIA replaces PAP, and if PAP was abnormal, you would have sent them to colposcopy in a developed country or in countries where resources are available. If VIA is positive, there are 2 options: to take biopsy or send them to colposcopy. So if you don't, if it's a minor change, sometimes they've done see and treat there, but major changes on VIA and many abnormalities, they've sent to referral centers for colposcopy, biopsy, and for the treatment with a leaf or a cone, etc. That's how it replaces. Again, in the field, it is different. When you're seeing screening programs of thousands and thousands of people undergoing VIA, the way that is dealt with is different, but an abnormal VIA needs further evaluation is what I'm trying to say.
Thank you very much. Okay, the next question is kind of for everyone here, and it's kind of very difficult to answer. How can we optimize the screening, early detection, providing appropriate treatment and care of cervical cancer patients during COVID-19 epidemic or political crisis in any developing country? So there's someone who's like to answer, or Professor Tati, maybe, since you have a lot of experience in the developing country or some under some kind of situation, very specific or special.
Thank you very much. Maybe for the promotion, prevention, and early detection. Yeah, for promotion, prevention, early detection in the COVID pandemic time, what we can do is to give a promotion, just a promotion. What is the early symptom of the cervical cancer, and ask the woman to come to the primary medical services if they have that kind of symptom. And for the treatment, what we do in our center, anyhow, we have to treat the patient. We have to treat the patient, but with a more simple way. More simple way, that means maybe we don't need to do the high technology technique of irradiation like intensity modulated radiotherapy, but we can use just a 3D external irradiation. And for the brachytherapy, as I mentioned before, we don't do the 3 times, but we use the 2 times brachytherapy for one patient, just to reduce the time for the patient to come to the hospital. That's what we do. And it seems that it can be done. It depends. When the number of new cases in our hospital is already reduced, so we make the brachytherapy against refraction for one patient. But if it is high, like the last July, our peak of COVID 5 times higher than the first peak of COVID, so we used 2 fraction for one patient. Thank you. That's what we do right now.
Thank you very much. Okay, so I have a last question. Is for me. So I read the questions. So I really appreciate the guy who asked this question. So the question is, as you know, cancer registry. So I'm measuring cancer registration. So I was working in Yangon and Nepido for development of cancer registry. And cancer registry is vital for implementation of any cancer project. And you have, so it is me, actively involved in the implementation of population-based cancer registry in Yangon, Myanmar. And I deeply appreciate it. As a working partner with you, I found all your effort highly valuable. And as things stand now, at this very moment, and how will you assess the degree of success in implementing population-based cancer registry in Yangon? So this is not compliment, and I was really kind of impressed by the speed of the development of population-based cancer registry in Yangon. So all the people who involved in this project were very active, from the government and from the hospital and from this kind of paramedical who went to the hospital to record the cancer cases. So I think it is kind of the fastest record, I think, as I experienced in my life, to develop high quality population-based cancer registry in one city or one region. And I really hope that it will expand to the other city, just like Taunji or the others. But really, unfortunately, now we have this COVID-19 and the political crisis in Myanmar. But I did not really kind of give up this project. So in the near future, after COVID-19 epidemics over, after political crisis is calmed down, I really would like to go back to Yangon and to continue and restart this development of population-based cancer registry in the country. So please do not give up, and we still want to support your country. So let's do it in the near future. Okay, so this is all the questions. I'm not missing any of you. It's okay. Okay, so now it's about time to wrap up today's discussion. So I conclude very briefly. I'm epidemiologist, so I'm not so familiar with kind of treatment techniques, but as I know that unlike other cancers, cervical cancer is more common in young women. So it's really different from the other cancers. And this is therefore, so it has kind of great impact on society and greater burden on the actual workforce or family structure. The incidence of cervical cancer in Asia, especially in Southeast Asian country, is kind of very high, and effective cancer control program is urgently needed. However, the prevention and early detection method have been established, however, unfortunately, yes. And they are feasible even in the low and middle income countries. And if early detection is linked to effective medical treatment, most of the patients are able to go back to the society while maintaining the fertility, for example. And I hope that all the participants here will join us in promoting measures against cervical cancer. So thank you very much, and it was long, so thank you for your patience. So I hand over to the Dr. Aung Naing Soe to finalize today's session. Dr. Aung Naing Soe, please.
Thank you, Dr. As being all the attendee has been asked about the guide for developing the resource-appropriate invasive cervical cancer management guideline. This is the document sample of that we've been published on our website. And I would like to rearticulate that after the session, we will be disseminating this guideline along with the recording and report of the session. And thanks to our speaker, Professor Shylasree from Tata Memorial Hospital, Professor Kim Pyone from Yangon, Dr. Lanka from Indira Trust Cancer Foundation of Lanka, and Professor Kim Joo-Young from the National Cancer Center of Korea, as well as our co-hosts, the Asian National Cancer Center Alliance, the National Cancer Center Japan, and Tata Memorial Hospital. We will be following up with you in the next couple of weeks to provide an executive summary report of this discussion, as well as the guide on how to develop the cervical cancer management guideline. And today's session is the last session of the Driving Quality of Cancer Care in Asia Regional Discussion Series. And we will also be sending out the report summary of the discussion series to the partners and attendees as well. If you have any follow-up or feedback for the sessions, please do not hesitate to get me in contact with me at my email address provided on the screen. Once again, I would like to thank to our series co-hosts, the Asian National Cancer Center Alliance, National Cancer Center Japan, Tata Memorial Hospital for collaboration and support to the series, as well as to the partners, Joo-Young Pharmaceutical and Icon Group for making this wonderful discussion series happen. We look forward to further collaborative work and partnering for the improving access to quality cancer care in the Asian region. And have a wonderful weekend. Thank you.
Thank you very much.
Thank you.
Thank you, one and all.
Thank you.